for people staying very far away, this is how it has to be. We stay so far away from.
Good evening, Arun Chaturvedi. And
Hi, good evening. Good evening.
Dr. Subramanian Rao. Good evening. I'm sorry, my video is not coming.
It's okay. It's okay, sir. We'll manage.
Right. Thank you.
Don't worry. So, Srijan, can you, I think, go on?
Yeah, another minute.
Yeah.
क्यों नहीं हो रहा? अच्छा, मैं तुमको अपना तुम्हारा मेल आईडी बताओ मेरे को. एक सेकंड, दोबारा बोलो. तो मेरे को व्हाट्सएप करो. हो गया. अच्छा, ठीक है. ओके.
Yeah, finally.
Siddhant has joined. He's finding it tough.
Okay, he'll be getting the tough questions today.
Hi, Siddhant.
Hello, ma'am. Sorry for the delay.
Okay.
In time, just in time.
Okay, we start in 5. Good evening, everyone. Welcome to the second chapter of the Masterclass series presented to you by IASO Academics. I welcome our President, Dr. Rajendra Toprani, to open the session.
Thank you, Srijan. The Academic Council, headed by Dr. Subramanian Rao and helped by Srijan and our 4 past presidents who are advisors, they are doing a fantastic job. And this is the second program in the second year. And today's topic would be carcinoma in situ of breast. To chair the session, I would invite Dr. Sadasivam, our past president, for taking over now. And the moderator would be Dr. Geeta. So over to you, Dr. Geeta. And before that, I'd like to introduce Dr. Sadasivam. He's the past president of IASO and retired professor of surgery at CMC Hospital, Coimbatore. And he was the organizing secretary at NatCon 2002 at OT, and we fondly remember that meeting. He's awarded the honorary FRCS from England. He also served as a past treasurer of ASI for 1 term and a GC member for ASI for last 6 years. So, Dr. Geeta, can you take over now as the moderator and invite Dr. Sadashivam to chair the session? Dr. Geeta is a senior director and a breast surgical oncologist and an oncoplastic surgeon at Max Institute at Delhi. And she is a vice president of Oncology Forum of Delhi, founder secretary of the Delhi Breast Oncology Group, and EC member currently of IASO. She's looking after our website. She is also an ex-EC member of ABSI and ISO. So over to you, Dr. Sadashivam and Dr. Geeta.
Thank you very much, Dr. Rajendra Toprani, for giving me this honor of chairing this session. I welcome all of you. I don't want to take much of your time. Please go ahead with your proceeding, madam.
Thank you very much, sir. May I now introduce the topic, which is in situ carcinoma of the breast. And we have 2 very renowned examiners for the same. So Dr. D.G. Vijay, he's a colleague and good friend, a senior consultant running the breast services at HCG Cancer Center in Ahmedabad, trained in GCRI, and he's the founder director of the HCG Cancer Center, Ahmedabad, and he also is part of the executive body of the ABSI, and he's kind of seen everywhere, and he's a faculty at multiple national and international breast conferences. Welcome, Dr. Vijay. The second faculty, again, possibly does not require any introduction, Dr. Gaurav Agarwal, again, a colleague and a good friend, president of Breast Surgery International, professor of endocrine and breast surgery, chief medical superintendent of SGPGI Lucknow. He is also the convener of the SGPGI breast health program, extremely erudite, has published extensively, and is one of the top 2% most cited scientists in the world, according to the Stanford University list. and he's a very popular speaker amongst all of us. And the third and a very close friend, Dr. Neeta Nair, again, consultant surgeon at Tata Memorial Center, Mumbai. She's a professor of surgical oncology, convener of the breast disease management group, and she has a lot of interest and she's driving some very exciting research in breast, and we're all hoping to be part of it. So welcome to all of you, and now I'll hand you over to Srijan to take us through how we're going to conduct this masterclass.
Thank you, ma'am. The examinees for today are Dr. Siddhant Singh, who's a resident in the Department of Surgical Oncology at Max, New Delhi. And he'll be accompanied by Dr. Ranjit Kumar, who's a resident in Department of Surgical Oncology at Basutarkam Indo-American Cancer Hospital, Hyderabad. Few instructions for the session. The first segment of this webinar would be a mock examination in which there'll be 2 candidates and 2 examiners and 1 moderator. For the candidate, we request you to give to-the-point answers. No candidate is expected to know everything, so there's no harm in mentioning because there's another student here, so it saves us time and maintains the flow. Our examiners have a habit of giving hints all the time, so it is an exercise to read their questions and their mind also. For our dear examiners and moderator, we request you to please make sure that both students get equal opportunity to answer the questions. And in interest of online viewers, both who are present live, as well as the ones who will be viewing it on YouTube later, we request you to give the expected answers to the questions that are incorrectly answered or remain to be answered. We have a lot of online participants. We have a lot of senior IASO members as well. We highly appreciate your presence, and we request you to post in your inputs as well in the chat box. And for the residents, this is a unique opportunity to clear your queries, post your questions for the examiners, and we'll discuss that in the Q&A session. The first segment will have 45 minutes plus minus 5 at halftime, and at the conclusion of case discussion, I'll be reminding the moderator. That's all from my side. I hand over this virtual mic now to the moderator, Dr. Geeta.
Thank you so much, Srijan. So now let me just quickly get to the case, because I really want to cover a lot of ground, because this is not an easy topic and there will be no end to the discussions that we can have. So I'll go straight to the case. And like Srijan said, let's keep it to the point. The more you answer and the quicker you answer, the likelihood of us going on to the next half of this discussion will happen. So all ears and eyes. So this is the first case, a 40-year-old premenopausal doctor who presented with a lump in the left breast of 2 months duration, adjacent to the scar of a previous surgery which was done about 5 years prior to presentation. The histopathology of that lump was an atypical ductal hyperplasia and no comorbidities. I have kept it brief. So now I'll hand you over to the examiners. The examiners, your call.
Yeah, so the obvious first question is, Siddhant, what else do you want in the history?
So progression with the size of the lump. How did she notice it? Is it associated with any pain? And is it associated with any other symptoms like fever? And is then from the history of the lump, will then from history of the lump, she'll have to we'll ask for some family history associated with any breast cancer or ovarian cancer in the family, any significant family history.
Yeah.
Can we request everyone else to mute their mics while the candidate is speaking? Geeta, please.
Yes, please mute yourself.
Or if
menstrual history, obstetric history.
Yeah, go ahead.
So, menstrual history, obstetric history, number of first age at childbirth, age of menarche, age of menopause has not been attained, and did she breastfeed the baby, age at first live birth, or any if she has children or not.
Great, you have covered pretty much most of the things. Maybe a couple of other things that are important. There is a history of a prior surgery at the same site. So perhaps you would like to know about what
Yes, sir.
was the... Yeah, go ahead.
Hello.
Yes, please go ahead.
Sir, I would like to know the history regarding any treatment like adjuvant therapy that was taken or chemoprophylaxis that was taken for the atypical ductal hyperplasia that was there earlier. And was she was on any surveillance mammographies so that which we can
Right. Yeah, that's important as well.
interpret.
So
If they're available.
Absolutely. So when
how would you
important...
classify atypical ductal hyperplasia? Are you looking at it as a pre-malignant condition or as a precursor for malignancy?
Sir, atypical hyperplasia is associated with high chance of relative risk for malignancy, as well as it has it is a non-obligatory precursor pre-malignant condition, sir.
Okay, just because to summarize all that you've already covered, so this is what you would like to capture in the history. Is there anything else you would like to ask, Gaurav, DG?
No, done. Let's move.
So this is the examination. So there is a 2 into 2 centimeter lump in the upper outer quadrant, deep to the previous scar, measuring about 3.5 centimeters. There is no lymphadenopathy, and the right breast and axilla are normal. Is there anything else that you would like to do in the examination?
So we go back to Siddhant. Siddhant?
Sir, I would like to examine the supraclavicular nodes also, and I'm pretty sure the examination was done in all the three positions that we do for this examination, and we'll assess the mobility of the scar, the depth of the scar. The lump, the mobility of the lump, the depth of the lump, the nipple areola complex, and
I think more than the scar, we are more worried about the lump, which is a new development. The scar has been around for about 5 years.
Right.
Anyway, go ahead. So you got a mammogram done.
Would you like to read that? You have the mammogram projected here and the ultrasound as well.
Yes, Dr. Ranjit.
Sir, ma'am, this mammogram is actually on the left side. We are able to see the nuclearular complex and the skin appears normal. There is a soft tissue density with microcalcifications that is present in the outer and upper quadrant of the left breast, and the calcifications are microcalcifications which are fine.
Okay.
Well,
What else do you want to talk about on the mammogram? What else?
Ma'am, I would like to speak about the architectural distortion and
Would you like to talk about the density?
Yes, ma'am. Yes, ma'am. ACR category. The breasts are high density. It looks ACR category C or maybe.
Okay.
And the posterior, the adequacy of the films, that is, the inframammary folds are not seen in the craniocaudal sections. That is one thing, ma'am. And regarding the lymph nodes, there are no any.
Would you see inframammary on the CC view?
No, ma'am. In the oh, sorry, ma'am. This was actually it got zoomed out.
So you see the intramammary folds in the MLO.
In the MLO, yes.
Yes. But I agree. The CC views they do leave a bit to be desired. But in what way is the CC view not complete?
Sir, regarding the posterior chest wall, but it is complete only, sir. The posterior wall is
There is something
near.
missing. There is something missing.
Yes, sir. The muscle.
So how will you say it is outer quadrant, inner quadrant? How will you say that?
Ma'am, actually, in the CC view, I will be able to say whether it is medial or lateral. So the lesion is on the upper side, so that is obviously a lateral part in the lateral part. Whereas in the MLA view, I will correlate with it. So it is in the upper part. So I would like to consider it. I would say it as upper outer quadrant.
No, there has to be a method, because I could put the film upside down. But there is a method by which we know what is outer. It is mandatory on the part of the radiographer to do that so that we know what is outer and what is inner. How do you know that?
I'm not aware.
Do you see any markings on this?
No, a marker is put on the to mention this site and the outer view. Generally put in a marker designating the right and left hand.
Okay, so there should be a marker. Fine. And anything else would you like to comment on this mammogram?
Regarding architectural distortion and the nodes, sir.
Do you see a node?
No, ma'am. I don't see any significantly enlarged node.
You don't see a node?
But that has a central fatty hilum, ma'am. But
That's right. So you should be able to see. Yes.
So there are a few nodes, but all have central lucency. Well, that's all right. Okay. And what else do you see projected here? You did say some microcalcifications, which I could not appreciate in this, but there must be some.
Zoom in view, I guess.
Okay.
And then the ultrasound, we can correlate with that. It's an irregular lesion which is heterogeneous, and it has got some.
So,
can you see the microcalcification on the ultrasound as well?
Probably, sir. I'm not sure.
Okay.
Siddhant, would you like to pitch in? Okay. Or if Ranjit wants to continue, go ahead.
There is a posterior acoustic shadowing, sir. So there seems to be
very good
some microcalcifications as well. There is.
Okay. So what else would you like to do? You have this imaging available. Or sorry, before that, what is your impression if you have to report this mammogram? What's your?
Sir, my impression would be it would be BIRADS 4.
BIRADS 4.
Yes,
would you like to qualify why BIRADS 4?
Sir, this lesion looks suspicious because its density is it's a soft tissue lesion is seen, as well as with some microcalcifications. And on ultrasound, the borders are not well defined, and it has heterogeneous architecture with posterior acoustic shadowing. So all these features are more in more towards malignant picture, sir.
What are the chances of a lesion being malignant when you classify it as a BIRADS 4 lesion?
Sir, BIRADS 4 is a wide spectrum, sir. So correct. It can be
A, B, C.
Yes, sir.
So what is the chances? So did 4?
Sir, pardon me, sir.
So he's asking what are the chances of malignancy if it is a 4A, 4B, 4C?
Yes, sir. If it is a 4A, the chances of malignancy will be anywhere from 5 to 25%.
Is it 5 to 25? Okay. Go ahead. 4B?
4B, it would be around 25 to 50%, more than 50% is worse.
So what I know is 5 to 15, 15 to 50, 50 to 95.
Yes,
Okay.
95. Sorry.
95. Gaurav, Vijay, any difference of opinion?
Agreed.
No,
Agreed.
yeah.
Fine. So I think we have a long discussion ahead. So let's quickly move on to okay, next good question. So would you like to do a digital mammogram over a conventional mammogram? So what are the advantages? I think the question is quite evident. And role of MR mammography in DCIS. Okay. Who wants to take it?
So before we go to this question, would
Yeah,
anyone? Yeah, let's go back to Siddhant, asking Siddhant if he would consider DCI. I mean, the topic for day is DCIS. So we are obviously discussing DCIS patient, but given this picture on mammogram and ultrasound, is DCIS your first diagnosis?
No, sir. It's a suspicious lesion on mammogram, and definitely I would like to do a biopsy with any female with lump with a history of previous surgery. I would like to rule out first malignancy. So DCIS on the basis of imaging, I will not be able to make a diagnosis in this particular patient.
Okay, agreed. And if you add to it the history, the patient having undergone a prior excision of a mass, which was atypical ductal hyperplasia, and has a recurrence at the very same place, how would that add to the diagnostic workup?
So there's around not in recurrence, but there's a 10 to 30% chance that the atypical ductal hyperplasia turns out to be a DCIS or an invasive malignancy. I'm not too sure about the chances of when it's a recurrence. What are the chances?
Oh, so it could well be
when a primary surgery is done for.
Yeah. So we do not know whether the primary surgery was a complete excision of the lesion or was it just a biopsy, and the patient might have been under surveillance. But okay, let's leave it aside. But the fact that the patient has had atypical ductal hyperplasia, does that put her at a specific risk of either DCIS or invasive cancer?
Yes, sir. Yes, sir. There is a very high chance that it can be either DCIS or even invasive malignancy, because over time,
either of them. So we can't be sure whether it is DCIS or okay. Now the next question for you is, would you like to do digital mammogram over, and how does it score over conventional?
So digital mammogram gives better resolution, and we will be able to alter the images while viewing so that we can get better appreciation over a conventional mammogram.
Any other advantages of digital? What is actually a digital? We call it full field digital mammography. How does it score over conventional mammography? I mean, one thing that you said, the resolution may be better, and what else?
We can zoom in on the magnification is possible with digital mammography compared to conventional mammograms while viewing. So it will help us to better appreciate for microcalcifications whenever they are there.
Okay, to save some time, if I ask you for 5 good reasons why you would prefer a full field digital over a conventional mammogram. You've given me 2. Siddhant, feel free to pitch in. Let's have answers from both of you.
And quickly, please.
Okay.
I'm not aware of any other reasons.
No problem. No problem. So yes, with digital mammograms, you have the possibility of storing them, manipulating the images, and specifically you can do 3D reconstructive studies or tomosynthesis, and that is a huge advantage. And generally, it is comparing over a period of time with the previous mammograms, it is easier. Should we go ahead with the role of MR mammogram, Dr. Vijay, or you want to discuss anything further?
No, we can go ahead.
So
Okay.
who takes this question? What is the role of MR mammography or MR breast
Sir,
MRI?
MR mammography is better at detecting DCIS, sir. Almost it has a sensitivity of 92 to 95% compared to mammogram.
In what
but
kind of DCIS? In what kind of DCIS?
It's the sensitivity increases with the increase in grade, ma'am. So in grade 3, the sensitivity rate goes to up to 95%. So, but the problem again is with the lack of specificity. So most of the other lesions may be picked out, which are not significant actually. So ending up with unnecessary biopsies.
Calcific or non-calcific DCIS? Which kind of DCIS would be better picked up with MRI?
With MRI, non-calcific DCIS will be better.
Okay.
So would you advise a MR for this patient, a 40-year-old lady? So at the end of the day, you are the treating
yes,
doctor.
Sir.
Would you advise an MR?
What
yes,
would be
because she is young and she has dense breasts, correct?
Yes, sir.
Very good. Okay,
and she's
you
very
have done the
strong
MR.
history.
What do you see on the MR?
Sorry, my mistake.
How do you generally describe MR findings?
Hyperintense or hyperintense lesions.
So you should know about what you see in T1 weighted, T2 weighted, what you see in subtraction images. These are the things that you should know when you're talking about an MRI. So what do you see in the film that I've put up? Quickly.
In the film I have put up, there is a T2 hyperintense lesion in the upper part of the breast, ma'am.
Yeah.
Which has a radial scars, like probably.
Okay. So you're seeing an enhancing lesion?
Enhancing.
Yeah. So what do you mean by the various kinetics that go with the MRI?
I'm not aware.
So let's just we'll stop there. So this is just, this is something I'm sure, Dr. Neeta will be covering as to how we've already discussed how it scores over it. Okay, so now what would you do next?
We'll go for an image-guided coordinatal biopsy from the lump.
Okay. Is that what Dr.
In the same sitting?
Yeah, go ahead, Siddhant. Sorry.
Ma'am, it's a part of a triple assessment.
Mm-hmm.
So we have done a clinical examination, we have done radiology, and for the pathology part, I would like to go for an image-guided ultrasound, image-guided coordinatal biopsy from the lump. And in the same sitting, I'll order for ultrasound axilla and SOS FNAC from the suspicious node Sylvani.
Good.
If there are any, correct. How many cores?
Sir,
4
six.
4 to 6.
6, 3, 4.
4 to 6.
4
minimum.
Okay. Can you describe? Yeah. So you've done the course. So these are the slides. Can you just quickly describe these slides, please? Just try it. Don't get worried about it. Just try, if you can.
It's showing the full proliferation of epithelial cells into the ducts in the top left slide.
Okay, and these two bits?
The
PR and PR. Okay, so what is
PR is? It's staining for.
Is it staining?
There's no.
So you're not seeing any brown here, okay?
No brown.
PR is not there, and PR you can see some patchy brown, very little patchy brown, okay? Okay, so this is what your core biopsy shows. Okay, so let's go on to the next. Okay, so what do you do next? Now you know that this is an intermediate grade DCIS, ER, PR, or ER negative, PR negative. Would you do a HER2 on it?
Role of
Not
HER2
required.
currently is not fully proven in case of DCIS, because in anyways we're not. But still, it's in the experimental phase. So currently, I would not order a HER2 for purely for a DCIS patient.
You would not. Correct. Okay. Next. Now, how are you?
So now,
What is the metastatic workup for this patient?
sir, it's not actually required.
Not needed,
Had
sir.
it been an invasive carcinoma, then we would have gone for a metastatic workup because it's a recurrent disease. But in a DCIS, from my side, no metastatic workup is as such required.
Would you like to do anything to the axilla at this stage?
So if
You have a
at the
diagnosis of
time
intermediate,
the surgery sir,
you have a diagnosis of intermediate grade DCIS, which is ER negative, and the mammogram showed at least one enlarged node, though with a preserved fatty hilum. Is there a need to do anything to that node?
so there's a doubtful role of sentinel lymph node biopsy in such a patient.
No, before that,
Because
you mentioned it, Siddhant. You had mentioned it a little while ago while you were doing
ultrasound
Very good.
axilla and efficacy of any suspicious nodes.
Right. So this is the summary of this patient. This is a 40-year-old premenopausal lady with a personal history of surgery and which was ADH, and a family history of breast cancer with a biopsy proven intermediate grade DCIS ER negative PR3 by 8.
Any further investigative workup that you would require in this patient?
No need, sir. I think this patient has been evaluated, so there is no need of metastatic workup in this patient. We can discuss with the patient regarding the procedure kind of such.
Would you consider the family history that this patient has as an indicator for some further evaluation?
Sir, with the family history and her age, we can consider for BRCA mutation testing, sir. But
yes, but what?
Is that how you would do it, Siddhant?
With a significant family history, young age, I would also offer her genetic testing.
So why do you say testing? Has there to be something else before testing? Something precedes testing?
Counseling.
Yes.
Concept.
Genetic counseling.
Very important.
Two things are important here. One is you do not jump on to testing without counseling. And in current age and day, you do not just stick to or restrict to BRCA mutation studies. You do genetic counseling and evaluation. And this may not necessarily be just BRCA. If you have to do a few other things, what else would you do? What other genes usually you would evaluate for?
Sir, BRCA1, BRCA2, P53 for leaf-money, CDH1, and
CDH1 is associated with what?
CDH1 is associated with lobular carcinoma.
So here we don't have lobular.
For P10 mutations and
P10, okay.
Which else?
Check 2 mutation
Check
also
2.
has a
And
relative risk.
Okay. So let me just.
PAL-B2 could be another actionable mutation that you would look for. PAL-B2.
Yes, sir. PAL-B2.
So does this patient require any treatment at this stage? She has just a DCIS.
Yes, sir.
Why?
Sir, even at this stage, she might harbor invasive ductal carcinoma, sir. And even if this DCIS, if we leave it alone, she might she is definitely going to get invasive ductal carcinoma, or even with DCIS, sometimes we can have in 1% there can be a node positivity. Eventually, it will be growing. So you want to treat the patient, sir.
Okay. So what surgical options would you discuss with her?
So the surgical options would be a breast conservative surgery with a combination of radiation. That would be better, sir, probably. Or else, if the patient wants, or if the cosmetic outcome would not be good after surgery, we will have to do a mastectomy, sir, plus or minus reconstruction.
Mm-hmm.
Okay. And regarding the axilla, I would like to do an sentinel if I am going to plan a mastectomy. If I am going to do a wide local excision, I can, even with wide local excision, I would like to do a SLNB, sir, in this patient.
Why?
Sentinel node biopsy. Sir, this is located in the upper outer quadrant, sir. So while even if I do a wide local excision there, I would be disrupting the lymphatics. So subsequent sentinel node biopsy, I will not be able to do it. So I would like to go ahead with sentinel node biopsy, and for the axilla and for the primary, after discussion with the patient, either a mastectomy or a breast conservative surgeries.
Siddhant, do you agree with this approach as far as the sentinel lymph node biopsy is concerned?
So even I would want to do a sentinel because it's seen when the mammogram or it presents with the mass-like lesion. There are more chances of it converting into a invasive ductal carcinoma in the final biopsy. So had it been only purely microcalcification, I would have just gone for a breast excision under the wide local excision of the lump. But since it's in the imaging also, it's a recurrent disease. In the imaging, it's showing a mass lesion also. So I would offer the patient sentinel lymph node biopsy.
Mm-hmm. Okay, so yeah, you have a question right in front of you. Who takes this?
Sir, wide excision is as good as for this. Basically, we have to differentiate between mastectomy and wide excision. So it's seen that although mastectomy is the recurrence rate after mastectomy is less than 1%, but it's more like an overkill for DCIS. So wide excision, DCS plus radiation, there's no survival. The survival benefit is the same in both the approaches, and in the ASTRO guidelines, 2 mm has been considered as a safe margin for excision.
Why?
For DCIS.
Why so? Why not just no ink on the margin? As we do for invasive cancer?
So DCIS, the pattern of spread of DCIS is different from invasive ductal carcinoma. Invasive ductal carcinoma, it respects the boundaries and it respects the margins. But DCIS, there are still some the number of skip lesions, multifocal areas and skip focal areas are more common in DCIS as compared to IDC.
Good answer. But would there, you did talk about mass-like and non-mass-like lesions and their differences between the two. If it is a mass-like and little or no microcalcification, still you would insist on a 2 mm margin? Well, let me tell you that this is just a trick question. Your answer that you gave earlier is totally acceptable, is correct. But just to extend this discussion, so there is some bit of diversity in thoughts in this regard. It's not universally accepted to have, the need for 2 mm wide margin for DCIS. But your answer is totally acceptable. Okay, can we go ahead?
Yeah. So this is what was done. So this is what you've already said as to when you would offer mastectomy or a wide excision. And this is about the margin. So we have enough recommendations coming from the big associations which says that 2 millimeters is a good enough margin. And we've already talked about how we were going to address the axilla and DCIS. You want to ask anything more on the axilla, addressing the axilla?
I think you can do it as a two-stage procedure if you are ready for that. I think you can do the primary and then wait for the final report and then address the axilla at a second stage. But you can also do it as a,
yeah, unless you're doing a mastectomy.
Unless you're doing a mastectomy. Correct.
Okay, so this is what is about the role of SA. I'm sure Neeta will be talking more about this. So let's get to the next bit of it. Does the receptor status affect your decision?
No, ma'am. Not on the type of surgery.
Not in DCIs, but maybe in invasive it would. Okay. So let me just take you quickly through, this is what was done in this patient, wide dissection and sentinel lymph node biopsy, because it was a palpable lump and the fact that she had intermediate grade DCIS. So this is what we got to see, predominantly intermediate grade DCIS with a single focus of microinvasion, all margins free and sentinel lymph node negative.
I think the students must realize that the specimen has to be sent for a specimen mammogram just to make sure that all the microcalcification has come out.
If there is microcalcification.
This lady had microcalcification.
Not very clearly, as you see in that mammogram, there wasn't. Most of what you're seeing on the ultrasound is actually the microcalcification which is confined to the tumor itself. But you don't see the kind of segmental distribution of pleomorphic calcification as you would in those situations where you would like to bracket those microcalcifications before you excise it. So this was a pretty confined, well-defined tumor. So that's the immunoprofile. We've already seen this. Okay. So we already talked about the genetic counseling and testing. So this, I'll just skip this bit. So now let's come to the adjuvant treatment bit, because there's quite a bit of ground to cover.
We would offer her post-operative radiation therapy because it was a big lump. Although the margins are clear, but although she's a young age, so these are factors which increase the chances of recurrence. So wide local lesion followed by radiation therapy.
Radiation you would get otherwise also, or would you not?
Radiation would be giving, ma'am, otherwise also.
Because what situations, what conditions can you skip, or where you can avoid radiation?
Sir, low grade, high, old age, comorbidities, low grade without necrosis, small tumor, we can still offer her without radiation. We can, because there is no overall survival benefit from radiation without radiation. There's only a difference of recurrence, local recurrence.
Okay, so don't forget this patient also had a microinvasion, though single focus on microinvasion as well. Okay, so that is as far as radiation is concerned. Any chance that we can do a partial breast irradiation for this patient?
So currently, the recommendations are only for whole breast radiation, but there are studies going on for partial breast irradiation. So
she's just 40.
40-year-old.
Okay, so the straightforward answer should be no. This is
in
not
this patient. I would not like to omit radiotherapy.
Whole breast radiation. Okay. Now, yeah.
No, sir. In this patient, we cannot omit radiotherapy.
So a lot of effort has been made to identify those patients who may not require radiation. I will not go through it. I'm sure Anita will touch upon this on the VNPI and the Oncotype DX DCIS score. Okay. So just coming to the last bits of this. So now you know what the treatment is. So Gaurav, would you want to
Yeah. So any role that I mean, surveillance post-treatment, are we talking of that, or surveillance without treatment? Is there a role for surveillance without treatment? Siddhant?
So, if the patient is not willing for radiation therapy, obviously we'll advise her radiation therapy. But if she's not willing for radiation therapy, we can still offer her surveillance with an initially 6 monthly and annually mammogram.
Okay, so that's post-surgery. What if the patient is not willing for any treatment whatsoever?
Because that is one of the greatest, criticisms of screening mammography, that it picks up a lot of early DCIS, which may not be fatal in the patient's lifetime. And we may be overdoing surgery in many of them. So is there a role for surveillance in some of them?
So there are ongoing trials like the LORD trial and LORDIS trial. They are looking at, but the results are not mature yet. So currently there is no evidence supporting surveillance, but still more studies and more randomized controlled trials are required to answer this question. So currently no.
Okay, so very low grade DCIS, non-mask like a high surgical risk patient. Perhaps there's a role for surveillance, but the surveillance it doesn't mean no treatment and no follow-up. It does require some bit of intense follow-up, so to identify any interval change and change in management plan too. Okay, is that all for this case, Geeta, or are we?
So I think so. So now what we will do is, I think we're well within time. So we'll just go through a rapid fire. So I will just put the case to you, and we will just get to the last bits of it, because the trouble is usually with DCIs, how do you manage such patients. So I'll just take you through. Let's see how many cases we can do. So this is a 51-year-old perimenopausal with a lump at the right breast of 4 months duration. So the right breast on examination is a 3 into 2.5 centimeter lump at 1 o'clock. Right breast about 1 centimeter from the areolar margin, and she's got enlarged axillary nodes also. So on ultrasound, there are few ill-defined ducts in the retroareolar region. Sorry, just a second. Let me just minimize this. Okay, with no intraductal soft tissue or internal echos, an ill-defined heteroechoic mass with significant vascularity, and some discrete microcalcification at 1 o'clock position in the right breast. Okay. So this is what you're seeing on the ultrasound. You can see some ducts there, and there is some vascularity there, some hypoechoic lesions within that breast. So this is what the ultrasound showed, and that is the mammogram. So the mammogram is not very helpful. So it's kind of dense breast, and you can see a vague lump on the CC view. So an MRI was done considering the density of the breast, and there is a lobulated altered signal intensity at 1 o'clock. Significant enhancement in the post-contrast study measures about 3.1 into 2.8 centimeters. And this is all happening in the right breast with a type 3 kinetic. So an ultrasound guided biopsy was done, and this came back as ductal carcinoma in situ. This was done outside, and it said intermediate to high grade, and microcalcification was seen on the biopsy as well. And this patient underwent a right mastectomy and a sentinel lymph node biopsy. Would you like to ask any questions here, Gaurav and DG?
Let us move on with the treatment.
Okay, so this is what the final pathology is, and this is where the things begin. So this is a microinvasive duct carcinoma, and the largest area of invasion is 1 millimeter. DCIS, solid and comedo. Of course, sentinel nodes were done because it was a mastectomy, 0 out of 2 lymph nodes. IHC report often reads like this: ER/PR negative and HER2 3+. So how would you manage this case from here on? Siddhant and Ranjit, your mandate on this patient.
The treatment of microinvasive carcinoma is debatable, and
yeah,
I would offer her. I would.
What would you offer her? One
observation
for each of you.
Only
observation I would offer.
Okay.
in this patient, we would go for observation.
Okay, so good. So this is what we would also do. It's a microinvasive carcinoma. Even if the patient was HER2 positive, to qualify for a HER2 targeted treatment, you must have at least a 5 millimeter focus of invasive carcinoma. So this is microinvasive duct carcinoma, and that's where the story ends. She's not going to be. Is she going to be on any hormonal treatment?
No, ma'am. Is
there a
ERPR is negative.
Treatment in ERPR negative patients?
In negative patients, it's not proven.
There
is no role.
Why you would give it?
Some patients might still
chemoprophylaxis
to prevent the recurrence of
chemoprophylaxis.
Positive.
All right. Okay, for treatment it would not be used, but for chemo prevention, contralateral prophylaxis, you may use it. Okay, so let's come to case number 2. 58-year-old postmenopausal lady presented with complaint of bloody nipple discharge from the left breast since April of 2021. Mother of one grown-up child and has a family history of breast cancer in her paternal aunt. On examination, there is nipple discharge from 11 o'clock position with the trigger point also at 11 and a tiny nodule that you could feel along the duct. Rest nothing, right breast and axilla nad. So this is the mammogram. If you were to look at it very carefully, what kind of Biret score would you give this mammogram? You have to look very carefully, huh? Quickly, Biret score. Ranjit and
would be Biret's 3.
Do you see something? More visible on this. Just look at this area. Can you see something? There is a small lesion that you see, which actually may be passed if you don't look at it very carefully.
Madam, the screen is not visible to all. Your screen is not visible. Your mammogram pictures, etc. I'm Dr. Sadasivam speaking.
You're not able to see the picture?
Yeah, yes, madam.
No, we are seeing, sir. We are seeing, sir.
Okay, anyway, I'm not saying. Okay, then go get along. Right. It's all right. If I don't see, it's okay. Right.
So if there is a suspicion and you're not able to clarify much on mammogram, what would you label it as?
Biret 3.
You would call it a Biret 0, because if you're not convinced, you think there is something more that needs to be done, you would label it as a Biret 0 if you're not convinced. If you were to look at it, you might. So, you may want to do an ultrasound in this patient. So this is what is the ultrasound. Do you see something now?
There is a lesion.
Hypoechoic lesion.
So you can see, you can see some hypoechoic nodules within the duct. Okay. Again, here you can see a lesion within the duct. So sometimes elastography does help you to figure out, especially when you see there is a blue color coding that is indicative of a malignant nature of the disease. Is there any other investigation you would want to do? Because this is kind of vague still. Do you want to troubleshoot? Any other investigation you want to do?
MR mammogram.
Okay.
I'll go for mammogram.
Dr. Ranjit?
Ma'am, I would like to go for BAPS.
Without doing a MRI. So I would not fault any of you, because if there is something that you can see on the ultrasound which can be biopsied, you can go for it directly. But if you want to know more about the extent of disease, an MR mammogram may be helpful. So interestingly, do you do a nipple discharge in all patients who have a nipple discharge?
It's very non-specific. Does
Right.
not have a very high sensitivity and
Right. So
specificity.
90 to 95% of times you may not get anything. Dr. Vijay, is that your experience also?
Very true. But much to our surprise, in this case, it has turned positive. So
Much to our surprise, because this is positive on discharge, but it is negative on biopsy, which only increases a conviction that you have to do something more for this patient.
We will have to do an MRI of the breast of this patient.
Okay. Okay. So now you say that we have to do an mammogram because we are not picking up much on the biopsy and the ultrasound did show a few lesions. So this is what you're seeing, small nodular lesions in the anterior and mid depth. Okay. So these are enhancing lesions. And there is non-mass like enhancement. So you can see that area. And you can see those enhancing nodules in the ducts as well. Okay. So even in subtraction images, you can see this area which is showing those lesions, and there is nothing else in the rest of the breast. Okay, so this patient underwent a major duct wide excision because it was really there at the nipple, and also a sentinel node biopsy. So you may ask me why we did that, because it was malignant on the and there was no way to tell whether it was what kind of thing it was, and the patient did not want a second surgery. So that's why we landed up doing a sentinel node biopsy in this patient. And her final pathology is an invasive cribriform carcinoma in the background of extensive proliferative breast disease. So the main highlight of this case is basically you have to keep your index of suspicion high, and don't let the patient go just thinking that everything is fine. What we're seeing is of no consequence. And in this patient also, the maximum invasive tumor dimension was only 3 millimeters, not microinvasive, but this is invasive. Okay. Okay. Any other comments or any other questions that you would want to put to the examiners on this, Siddhant and Ranjit? Okay. So the last case that I would like to leave you with, who has still not come back for further treatment, is a 71-year-old asymptomatic postmenopausal lady. She had a screening mammogram done when her daughter was diagnosed with breast cancer aged 47, and her father had pancreatic cancer too. This is a mother that we are talking about. And on screening mammogram, she had an asymmetric density in the upper central region of the left breast, with an area of clustered pleomorphic calcification associated with this density, and another grouped calcification in the lower central region. So there are two regions of pleomorphic calcifications. I will try and run this. So I'm just going to do the tomo bit of it, just watch this. You can see the calcifications coming up and then disappearing. So again, you can see those calcifications, very, very segmental kind of calcifications that you can see. You can have another look on the CC view. Are you able to appreciate it? Okay. So this is the situation. So what is your BI-RADS score? I'll just run this thing again and try to stop where you see the microcalcification. Can you see the microcalcification here? Are you able to see that?
Yes, ma'am.
Okay. So what is your BI-RADS score? When you see microcalcification, what would be pleomorphic microcalcification? What is your BI-RADS score?
4B.
4?
4B, ma'am.
B.
This patient has history of family history is there.
Okay. 4. See, when you see a pleomorphic branching, very, very segmental distribution of microcalcification, you can safely label it as 4C. Nobody would fault you for that. Okay. So this lady decided to have MR mammogram also, because she thought that we were just overreacting to the situation. And this is what we got to see on the MRI also. So this is what you're seeing. Okay, a very enhancing lesion in a very segmental distribution. So it shows progressive clump nodular non-mass-like enhancement in the upper central region of the left breast, but there is no MR correlate to the calcification in the lower central region. So they have labeled it a BIREDS 4. A biopsy was done from the upper central region, and that has come back as benign with changes of fibroadenosis. So what would be your advice to her?
There's a clinico-radiological pathological discordance.
Okay.
So we can advise go for a repeat biopsy, and if it again comes out to be negative, then we can go for an excisional biopsy in this case.
Would you do anything for the other, the lower central region calcifications?
Yes, we can go for
that has to be also be biopsied.
So, Dr. Gaurav and Dr. Vijay, your comments on this as well.
I think if it was the index of suspicion was as high as 4 and 4C, probably, I would probably advise an excision.
Both lesions.
On the MR, it doesn't, the one in the lower central region doesn't correlate on MR.
But there are microcalcifications. So these are real life situations.
I know.
So Neeta, what would you do?
So I think as if you've got discordance, you just biopsy both of them again.
Okay. So the lower bit is tough to biopsy, but yes, a stereotactic is possible because it is microcal, so they can possibly attempt a stereotactic on both, in fact. Okay. So that is that. I think we are done. Just to show you one of those mammograms, which is very, very classical, extensive, branching, pleomorphic, microcalcifications occupying almost half the breast. And this is the kind of breast where you would possibly not advise conservative surgery. So I'll leave you with those thoughts as Neeta takes over for the next segment. Over to you, Srijan.
Yeah. Thank you, ma'am. And thank you, Dr.
Candidates did very well.
Yeah, so I wanted to invite comments from the examiners and moderator.
Yes.
Gaurav first.
I think he's not available right now, sir. Could you please
I think he's left. He had
for
to
him?
leave, I believe.
Yeah.
I think both the candidates did very well. Geeta, I'm sure you'll agree with me.
Of course.
DCIS itself appears to be a very innocuous disease, but there are a lot of intricacies to the whole subject. And as you go deeper and deeper, a lot of things come up. Even the slides were excellent. And I'm sure that there is a lot of material that has opened up, and the boys will read, and by the time the exams are on the counter, I'm sure they will be very well prepared. And this entire IASO exercise will help them in preparing for the exams. And all the other students who are online will also benefit from the entire exercise. Thank you.
So I also think that the examinees were very good. In fact, much better than what we were at the time that we were that age. I'm very sure about that. But one thing that you must understand, so whatever you do in DCIS, which is almost akin to what we do for IDC, you should not feel very apologetic about it, because our patients are not the screen detected cancers that you see in the West and for which all the recommendations exist. So ours, pure DCIs, I'm sure Neeta will tell from her experience also that pure DCIs are very far and few. So I don't think we see more than 2 or 3 pure DCIs in a year, which is kind of very, very insignificant if you were to ask me. So just stick to what you're doing. You're doing absolutely fine. So when and whenever screening were to happen, we will have a bigger discussion on this. Till that time, you can just keep doing what you're doing. Thank you. And well
Thank
done.
you so much, ma'am.
Both of you.
Thank you, ma'am.
Professor
Thank you, sir.
Savadasam, sir, do you have any words of advice for the students here? You're muted, sir.
Thank you very much.
Yes, sir.
An excellent, masterclass demonstration. I have learned a lot from the youngster, from Madam Geeta, and both the examiners, and to all who has organized it. All the best for the candidates. Thank you very much.
Thank you so much, sir.
Thank
We
you, sir.
move on to our next segment, which is the statistics segment, and we will follow that up with Dr. Neeta Nair's expert talk. So the primer segment for today is the basics of a survival curve. And the speaker for today is Dr. Senthil Rajappa, who's a senior medical oncologist from Basutarkam Cancer Hospital, Hyderabad. I request everyone to pay attention to this segment for the next 15 minutes, which will be then followed by the expert talk. Thank you.
Senthil, we can't hear you.
No audio, Rajan.
I'm so
Rajan,
sorry.
there is no audio.
I'm so sorry. 1 second.
Geeta, it's recorded.
Yeah.
Okay.
Good evening, everybody. This is part one of a two-part series on Kaplan-Meier survival curve, something that we very routinely use in daily interpretation of medical data. So just to start with, this is the curve that probably changed the world of statistics and interpretation. This curve was put forward by two gentlemen. One is Edward Kaplan and the other is Paul Meier. And this was in 1958. What they did was a Kaplan-Meier estimator. Now, what does this do? This helps in estimating the proportion of patients who are alive at any time point. So this word time point is very important, and we will keep talking about this again and again during the course of this lecture. And this curve that we plot is called a Kaplan-Meier curve. What do we actually do? This is a survival analysis. So again, as I started by saying, the word time is very important. So this is a time to event analysis. You can look at many events as part of a Kaplan-Meier projection. The event could be disease-free survival, progression-free survival, overall survival, or something else like CNS failures, peritoneal failures, and so on and so forth. So there are many events that you can look at as part of the time to event analysis in a Kaplan-Meier projection. Now, this lecture is not about how you go about plotting a curve. This is about how you go about interpreting the curve. Now, irrespective of when your patient is enrolled into a study, all of them start at the same time, and that is here, which is at time point 0. The x-axis shows you time in months, the y-axis shows you the survival probability. So all of them start at the same time. And then you see that these are divided into time parts. Now, what you look at here is an event. So any drop in the curve, a vertical drop in the curve signifies an event. The horizontal part of the curve where it's flat signifies that nothing in terms of an event is actually happening there. The third thing that you're seeing here on this curve is this red tick or a red vertical line. Now, what does this red vertical line signify? This is something that is called as censoring. Now, what does censoring mean? This includes a patient or someone on the study who is lost for follow-up without the event that you're looking for having happened in him. Or your patient could be off the study without the event having happened, or this patient could be off the study because of some other event which is unrelated to the study. When I say unrelated to the study, I'm talking about unrelated to the study endpoint. For example, if you're coming off the study because of an adverse event due to a treatment, and this adverse event due to a treatment is not an event as per definition of the endpoint, then that is also a patient who will be censored here. What is the importance of censoring? The importance is that more the censoring, the less the reliability of this curve. Now, how many patients or what proportion of patients should be there in order to call this curve reliable is something that we don't know. We haven't agreed upon that. But what's more important to understand is that it's the events that matter, because the reliability of this Kaplan-Meier curve is more dependent upon event than just the number of patients who are there at risk at any point in time. So all of them start at the same time. Every drop in a curve is an event. There are patients who are censored, and then the flat lines that you're seeing there, or the horizontal parts, are times at which nothing or no event is actually happening. Now you see that this is a stepwise downward line. Why is then this called a curve? This is probably a plot of a study where there were just 8 or 10 patients. So you're seeing what happened to each and every patient on this Kaplan-Meier projection. But when you look at a study that has a few hundred patients, you won't be able to really make out on that curve that is being shown on the journal or the projection as to when an event happened for an individual patient, when each of these patients were censored, and so on and so forth. So this serration that you see as horizontals and downs will actually look like something that's very smooth, and that's why you call this a curve. So neither are we looking at survival all the time, nor this is a curve. So in both ways, calling it a survival curve can actually be a misnomer. What are the two important things that you're trying to look for in a Kaplan-Meier curve? The two important things are median overall survival. What is the median overall survival? This is the time at which there is a 50% probability of surviving. How do you look at this? You just look at 0.5 here. So that's 50% survival probability. Draw a horizontal, and wherever this touches the projection, you drop a vertical from there. So here, the median overall survival is about 6 months on this curve. The other thing that you can look at is survival at a particular time point. That can be 6 months, that can be a year, 2 years. You just do the reverse. You first draw the vertical upward. Wherever it meets the projection or the curve, you draw a horizontal to the y-axis from there. That tells you the percentage of patients who are surviving at a particular point in time. So these are the two most important data points that you're looking at in a Kaplan-Meier curve. Now, what are all of us interested in? We are all interested in comparing two survival curves, which means whenever you're looking at a randomized controlled study, you have two curves, the curve for the standard arm, the curve for the test arm. Now, what I'm showing to you on this screen is a randomized trial of two interventions. One is a drug called dacomitinib, the other is called a drug gefitinib, which are used in advanced lung cancer for EGFR mutant patients. Never mind what the context of this study actually is. Now, you're seeing here a Kaplan-Meier projection. Now, what you also do when you're interpreting this is measuring the effect size, which means, is one treatment better compared to the other? If the answer is yes, how better it is. So that's what you call as the magnitude of benefit. All right. So now let's go slowly interpreting each of these numbers that you're seeing on this screen here. The first one is something that we already spoke about. It's the median progression-free survival. Now there we said median overall survival. Here we are seeing median progression-free survival. the time at which there is a 50% probability of being progression free. That's 14.5 months versus 9.2 months. So that's point number one. Point number two is also something that we already looked at. We are talking about the PFS rate at 2 years here. We spoke about 1 year and 2 years in the previous slide. We are speaking about the progression-free rate, or the percentage of patients who are progression-free at the end of 2 years. So that's 30.6 versus 9.6. Now, what else are we looking at here? We spoke about patients as risk. I briefly mentioned about this word risk. When you come to the bottom part of this curve, you see these numbers. These are patients at risk. These are patients, all patients who started on the trial are at risk for the event at time point 0. So you see 227 patients, 225 patients on DACO and gefitinib respectively. So all patients who enter the study intent to treat are at risk to get an event while on this study. What happens when you come to 6 months, 12 months, 24, 36, and so on and so forth? You see that the number is dwindling down. Why is it dwindling down? Because of two important reasons. Event is happening. So that's one. So in a set of patients, they are having the event of interest, which is progression here in this particular curve. The second is some of these patients are actually getting censored, which means we are losing some of these patients for follow-up without the event having happened. We are also losing some patients for issues that are unrelated or maybe remotely related to the study. So these are two patients who are not at risk at various points in time, depending upon whether they were censored or whether they had the event of interest. Now, why is this number at risk important? Again, remember we spoke about reliability of the curve. Now, as you go to the right, as the numbers keep coming down, you see that the reliability of the curve keeps going down. But again, this is very relative. We are talking about events. As number of patients at risk keep going down, the event also goes down. When the events go down, you also have lesser reliability. Okay, so this is something that is very important to understand when you're looking at a Kaplan-Meier projection. Now, remember, whenever we are talking about significance or whenever you're talking about difference between two interventions, we can just look at the number of events with treatment A, number of events with treatment B, and then use a log rank P to say whether this is significant or not. Why is it that this is not the best way to look at the difference in a Kaplan-Meier projection? Remember the word time. When you're looking at events, you're looking at events at a particular point in time. When you're using a log rank, most of the time, this time point is at the end of the study, right? Now, we are looking at the significance of the difference between events with intervention A versus intervention B at the end of this study. So this log rank P, or comparing just the events, is not time sensitive. How do you make this time sensitive? That's where the issue of hazard ratio comes, which is one of the most important numbers that you have to understand in a Kaplan-Meier projection. What is hazard ratio? A hazard is something that is not good, isn't it? So hazard is an event. What is this hazard? It's an instantaneous event rate as shown on this slide. What is this? This is a probability that an individual at a time t has an event at that particular time. Now, what is this? We are talking about hazard ratio in a Kaplan-Meier projection. So if you're looking at the hazard in the treatment versus hazard in the control, what's this? That means the probability of having an event at a particular time with the treatment or the test versus the probability of having an event at a particular point time t in the control is what is called as a hazard ratio. So let's go back to our Kaplan-Meier projection. Here, what does a hazard ratio of 0.59 mean? It means that if you take dacomitinib, your risk of progressing is 41% lesser compared to if you took gefitinib. So if you take dacomitinib, your risk of having an event, and in this case, it's progression, is 41% lesser compared to if you take gefitinib, which means that it is beneficial to take dacomitinib compared to gefitinib. So that is the simple interpretation. Now you see a bracket there showing 0.47 to 0.74. What is this? This is something that is called a confidence interval. Now, if you do this 100 times or 1,000 times, remember that you will not get the 0.59 every time you repeat this experiment. Now, when you're talking to your patient in the clinic, what are you going to say? You will say that the risk of progressing will be about 40% lesser relative to if you took gefitinib. But is that going to be as perfect as that number every time that you talk to a patient? No. Why do you need this confidence interval? Because if you do this intervention in the clinic, there is a 95% likelihood, or you can be 95% confident that the benefit that your patient will get out of this intervention will lie somewhere between 0.7 and 0.47 and 0.74. Agreed? So not all your patients are likely to get a 41% risk reduction. Some of your patients might get a better risk reduction. That means they might get a 53% risk reduction. Some of your patients might actually get only a 26% risk reduction. So the risk reduction, the magnitude of benefit that you're talking about here lies somewhere in between these two. And 95% of the times you're likely to fall somewhere in between. What about this p-value? The p-value is to say how sure you are about a result, not how good the result is. Okay? Not how good the result is, but how sure you're about this result. Now, what does a p-value of 0.0001 means? It means that if you repeat this experiment 10,000 times, that means if you compare DACO and gefitinib 10,000 times, it is in one of these 10,000 that you are looking at this result as a by chance result. In all the other times, it is likely to be a true effect, which is what we are interested in seeing. So the question is, which is the best parameter to assess for magnitude of benefit? Should be the median overall survival or the median progression-free survival? Should it be the survival probability or at 1 year or 2 years? Or should we be using the hazard ratio to look at the magnitude of benefit? That is something that we will look at in our next lecture series in part 2. Till then, ruminate over everything that I have told you today, and we will meet you in a couple of weeks again to tell you more about the Kaplan-Meier projection and so on and so on. Thanks so much and see you again.
Thank you so much, Senthil sir, for that talk. And we look forward to the part 2. Now I invite Dr. Neeta Nair, ma'am, for the expert talk, which would be on DCIS. I request the participants to post in your queries, either from the first segment of this webinar or the second, and we'll take up with our experts at the end of this session. Neeta, ma'am, over to you.
Thank you so much. At the outset, I'd like to thank the organizers for this. I'm going to say that's a very tough act to follow, Senthil, but I'm going to try with a very basic talk on DCIS. You heard a lot being discussed on DCIS during the entire session with the examiners. So we're just going to take this through to understand how we collate that evidence and how we collate that data together, and what really are the controversies that are still there. Sorry, Srijan, can you see my slides?
Yes, Neeta, yes.
Right, thank you. So just as we've all talked, and I think this is very basic, but just to reiterate the same concept, DCIS is primarily in situ cancer. It is defined by the concept of not having breached the myoepithelial layer. It is unfortunately a very heterogeneous disease. And you've heard a lot of conversations, you've heard all your examiners talk about how there is a difference in presentation, morphology, which group you need to treat, not treat, are there various considerations. It is, of course, a precursor lesion with a very high relative risk to develop invasive carcinoma. And this data of relative risk of 8 to 11 comes from the DuPont and Page paper. So for any of the students who haven't read DuPont and Page's paper on benign diseases, please go back and see that. So terminology, before we go ahead with the rest of the talk, that you need to familiarize yourself with when you're treating DCIS is exactly how Geeta asked in the beginning of the presentation. Do you look at it in calcific or non-calcific DCIS? So that's radiology based. Comedo versus non-comedo necrosis, that's pathology based. And of course, presentation, which is whether the patient was symptomatic, came with nipple discharge or a palpable lump, or whether this is screen detected DCIS. All of this is going to impact how you approach a patient with DCIS. Some of these slides, of course, are courtesy of Selvi. DCIS with comedo necrosis is because you're seeing cells within the duct undergo necrosis, and those are now becoming calcified because they are dying. That will be a very segmental distribution. You'll see it follow the pattern of the duct. It'll branch out like the ducts, and it'll have sort of an apex or a triangle with its apex towards the nipple, just as you see with the ducts. This is very pathognomic of comedo necrosis. For non-comedo necrosis, you may see more of a crushed stone appearance because it's not just the cells within the duct, but the fluid around it that tends to calcify. So that gives you a slightly different presentation and appearance on mammography. DCIS, unfortunately, now accounts for 20% of cancers that are newly diagnosed with all of the mammographic screening that is rampant in the West. We need to understand what the difference between the types of DCIS is, because some of them will progress to invasive disease, but often enough, most of them will not. Your presentation of DCIS for your patients may be just incidental screen detected lesions, nipple discharge, palpable lesions, which are pure DCIS, which is fairly rare, or associated with IDC, where you will see DCIS with or without EIC in the pathology. Any patient that presents to you, screen detected or not, will have a triple test, meaning that if she came screen detected, her imaging is already done, you're going to do a good clinical evaluation and then plan pathology, or she starts with a palpable lump, then radiology and pathology. So you cannot take that away. I'm not going to get into the basics of a mammogram because you saw a lot of that being discussed in the case. But is there really a role for a lot of additional imaging and MRI in DCIS? We know that the MR sensitivity for invasive tumors tends to be very high, even though it's not a very specific investigation. For DCIS, and particularly for low to intermediate grade, the sensitivity also is a lot lower. And unfortunately, MR may over or underestimate the extent of disease. Just to show you a few examples, is you've got a young lady, 29-year-old, who presented with a palpable lump in the left upper inner quadrant. She's got a heterogeneously dense breast. She's a young lady. We've chosen to go ahead and do an MR, which showed us primarily the same area that the mammogram calcification did show us. It did not add to anything, but we've chosen to go ahead and do the MR because there is clinical radiological discordance in terms of a heterogeneously dense breast. The same thing, if you were to look at the other lady who presented with a large lump and locally advanced tumor on the left side, we incidentally picked up microcalcification on the right, and the extent on the MR was much more than that on the mammogram. And the non-mass enhancement that was seen even on the right side was much larger than that on the mammogram. And if you look at it, if anything, this was a false negative, I would say, of the MR, where they suggested that that retroareolar lesion was probably not suspicious on the MR. That also came back as high-grade DCIS with necrosis, and this patient had opted for a bilateral mastectomy, which is why we know the pathology of all the lesions. The point being made is that what really is the role of an MR? So you know that it is better with higher grades of DCIS. A lot of the presentation for DCIS on MR will be that of non-mass enhancement. You'll see a mass in only about 14 to about 30% of the patients. And what you definitely know is that it's not something that has to be done for all. This is a large systematic review which looked at 3 RCTs, 23 observational cohorts, and this was published in 2021, 20,000 odd patients, where the evidence to suggest that if you initially had a BCT, is the MR making any difference to your reoperation rates? Both among the RCTs and the observational studies, there was no difference. Also, it may have changed the initial plan because you will pick up a lot of additional lesions, a lot of additional activity on an MR, which isn't very specific. MR-guided biopsies are not as easy to do. Most of us often go back and do a second look ultrasound and try and biopsy something. So in about 17% of the cases, there was a change in the initial treatment with no effect on locoregional recurrence. So there does not appear to be an improvement in surgical outcomes with the addition of an MR with DCIS. I will bring to your notice that all of this data, or a large proportion of this data, comes from cases where it is screen-detected DCIS, a large proportion of which may have been low grade. So where do we really stand with respect to the role of an MRI for DCIS? We know that for high-grade DCIS, it will have more sensitivity. If there is clinico-radiological discordance, I would say that's probably one of the only aspects that we'll go ahead and do an MR, which would include non-calcific DCIS, which would include women with dense breasts. You would want to do it for high-risk individuals. And if you are planning large oncoplastic procedures, just because you don't want to have to go back in. It is, however, not mandatory for all patients who present with DCIS. So once you've got your imaging in place and you're going ahead with a biopsy, for DCIS, you have some of the most obvious diagnostic procedures. You've got either, if she's got a palpable lump, you're going to do a core biopsy, preferably guided biopsies. If she's got nipple discharge, you go ahead with a microdocectomy. However, if it's just calcification, you have two options, one of which is a stereotactic biopsy for diagnosis, and the other being a wire localization. Just as Dr. Vijay mentioned, in both cases, where every time you do a biopsy or an excision related to microcalcification, you would want to do a specimen mammogram to confirm that the calcification are all out. Fortunately, actually, in this specimen, even on the gross, you can see the calcification there and there, which we were able to confirm on that. This did, however, come back as benign calcification. Any other options that we have, if you don't have access to stereotactic biopsies, is a wire localization. You always get a specimen mammogram done. We even do specimens of the image or the specimen after it has been cut and grossed, so that we're able to identify which section we're looking for the calcification specifically in. This is mandatory and something that you need to sit down and discuss with your pathologist when you're evaluating or diagnosing a case of DCIS, and especially when you're evaluating a large lumpectomy related to DCIS, and I will show you why. So the other options, of course, a microdocectomy. You can take a radial incision, you can take a circumarular incision. We've chosen to go radial here because there is a palpable lump. So we've got the duct, we've got parenchyma going all the way up to the lump and excised it. And this was IDC with DCIS. So one of the challenges that we definitely all face regularly when we're treating DCIS is to be able to distinguish indolent low-grade DCIS, which is what we think is a lot of the overdiagnosis related to screening, versus more aggressive DCIS that have the potential to progress to invasive tumors. So when you talk about screening and why there's such a buzz about DCIS being the part of overdiagnosis, this is one of the papers, again, by Laura Esserman, and I'd request all students to go back and read it. It's on the overdiagnosis or rethinking the screening in breast and prostate cancer, where you talk about what we've seen a rise in with screening is early stage cancers. And a large proportion of this early stage cancer is DCIS. We've gone from that to now discussing, do we really need to treat all that low-grade DCIS? Why we're talking about it is because you know from autopsy studies that a large proportion of patients have incidental tumors, whether it's precursor lesions, whether it's in situ cancers, and they would not have presented with the same, and they would have never been labeled patients or cancer warriors, so to speak, because we picked up these indolent lesions. So what we've moved towards now in the world is evaluating this difference. And in low-risk DCIS, we are moving towards more active surveillance and hoping that that's what these 3 studies will eventually show us. The studies are now looking at if you diagnose low-risk DCIS with multiple biopsies, can you just offer active surveillance versus standard treatment, which would be an excision biopsy with or without radiation and or hormone therapy, dependent on the case may be. But again, all of that is low-grade, low-risk, screen-detected DCIS. Today, the management of even screen-detected DCIS, irrespective of grade, continues to be surgery, radiotherapy, and or hormone therapy. The surgery could be a lumpectomy or a mastectomy, depending on the extent of disease. Sentinel nodes are offered along with mastectomies. It can be avoided in a lumpectomy in a low-grade DCIS. Radiotherapy, I will discuss again in more detail, and hormone therapy, of course, for the ERPR positives. But do we clump palpable DCIS in the same basket as screen-detected DCIS? What you need to understand is there are no treatment guidelines for palpable or microinvasive DCIS as a separate entity. The first reason being this is actually quite unique to countries like ours, where screening mammograms are not national programs. So our patients do not present a screen-detected DCIS. We do not tend to overdiagnose those DCIS which are going to come in, which are never going to present. We actually pick up larger palpable lumps. Now, when you see someone with a palpable lump, de-escalating treatment for screen-detected versus de-escalating for palpable DCIS is a completely different ballgame. Palpable DCIS can have up to a 15% risk of harboring invasive tumor, and you need to treat it with that in mind. DCIS with microinvasion is one of the biggest concerns with any palpable DCIS. And I think with all cases that you saw Geeta put up there, most of those cases had some focus of microinvasion. Now, DCIS can present as pure DCIS, which is a lump palpable. It can present as a foci of microinvasion, multiple foci of microinvasion, or DCIS in the background of a large IDC component. Now, the AJCC classification classifies DCIS as 1 mm foci. There are a couple of definitions that have also taken up to 2 mm when there is a single focus. What I would bring to your attention is there is work from Mascarell's group, which is the MD Anderson data, which shows us that there are actually 2 types of entities that you need to think about when you think even of DCIS with microinvasion. Having a single site or a single focus, or 1 to 3 foci, which is a small burden of invasive component in that palpable mass, will probably behave similar to DCIS, versus when you have multiple clusters of microinvasion, all of them 1 mm. So you don't add them up, they don't become 5 mm because there were 5 clusters there. There are multiple foci, each of which is 1 mm. This is going to do worse than routine DCIS and needs to be treated differently. You're never going to see level 1 evidence on this kind of data because this is very small burden of disease, but it is something that's unique to a country like ours because we do see more of it than the West ever will. What we need to keep in mind is factors that predict for the presence of microinvasion. If it's a large tumor, it's palpable. If you've got comedo type of necrosis, if it's ER negative, all of these would potentially have possible microinvasion in that tumor. So this is what brings you to your discussion with your pathologist is when you excise a lump, if the core was DCIS, your pathologist needs to gross that tumor more finely, look for these foci of microinvasion and quantify the foci of microinvasion so you are able to treat your patient appropriately. This is some work by one of our students who's now a consultant at D.Y. Patil in Mumbai, where we looked at 10 years worth of data at Tata Memorial Center, 784 patients with DCIS in their specimens. Only about 14% of these, and I think Geeta also very graciously said that you see 1 or 2 a year. At a center like ours, we're not seeing those many. We see maybe 113 of what is pure DCIS. 87 of them will have an additional focus of microinvasion, and the rest have associated DCIS with IDC, which can be T1A to T1B, and of course, some T2 tumors. At a median follow-up of 86 months in these cases, you will see that the tumor in situ or DCIS, and TMIC probably behaved fairly similarly, but you did see distant recurrences in the TMIC and the T1A. And a lot of this may have been because we have not completely quantified the extent of microinvasion and may have limited our use of adjuvant chemotherapy for extensive foci of microinvasion in ER-negative tumors, and that's possibly what's resulted in a poorer outcome. So our cohort did show that there was a higher focus of microinvasion of as high as 43% with palpable tumors, and we do propose that all centers reconsider their grossing techniques to identify and quantify the foci of invasion, redefine what is DCIS with microinvasion based on the number and size of foci, and therefore consider possible roles of adjuvant chemotherapy in large palpable DCIS with or without foci of microinvasion. Now that is just food for thought, but that's where I think we're moving towards. While the world is de-escalating on DCIS, which is low risk, we need to probably escalate our treatments and systemic therapy for higher grade, larger palpable DCIS, especially those with microinvasion. Which then takes you to, is there a difference in the extent of surgery that you offer your patients? Large set of data which tells you that between a lumpectomy and a mastectomy, there's no breast cancer specific mortality difference. There is, of course, however, a little bit of a local recurrence difference, none of which is significant. You can use the VANU prognostic index, which is the USC modified version, which takes in age with the criteria. You offer excision alone without radiotherapy for the low risk, small tumors, elderly women. You offer radiation for the smaller excisions with higher grade and younger women. And of course, with extensive disease, you offer mastectomies. But I think a lot of it just depends on how much DCIS you have in that area or available to you. If your mammogram picks up just a couple of foci of DCIS and microcalcification, can you conserve that breast? Versus something similar to this, or what the last slide that Geeta showed you, which had extensive DCIS across an entire quadrant or an entire half of the breast, you'd possibly want to offer your patient a mastectomy in that situation. Management of the axilla, unfortunately, is not as simple as do a sentinel node biopsy if you're doing a mastectomy. Don't do a sentinel node biopsy if you're doing a lumpectomy. You can do it as a second stage procedure because, again, I reiterate the same point. This isn't just screen detected DCIS. Those are guidelines for screen detected DCIS. This is a paper by Sandra Swain, which was published in 2004. Large number of studies on pure DCIS, DCIS with microinvasion, and I would beg you to notice that this is all screen detected, and as high as a 5.1% risk of sentinel node positivity in patients with DCIS with microinvasion. Please understand this is going to be much higher in palpable DCIS, where your risk of microinvasion increases and your number of foci increase. Very astutely, we heard the students talk about margins and saying that 2 mm is what is considered as adequate. Of course, what you need to understand that 2 mm comparison is to the 0 or 1 mm. There is no comparison made between less than 2 mm and up to about 1 mm. So we don't really have that answer, which is that would 1 to 1.9 be adequate also, but we take 2 mm currently as our adequate margin. What you need to understand is what happens if you have a patient who has a single margin, which is less than 2 mm. So it's technically positive, but she does not have EIC. She's low grade or DCIS, no IDC component, is going to get RT, and it's a single margin. Would you always go back and revise that? So when you look at the MD Anderson multidisciplinary practice of patients with less than 2 mm receiving adjuvant therapy, there was no difference in loco-regional when compared to patients with greater than 2 mm margins. So I would suggest that every time we're looking at a patient, it's not as simple as just 2 mm. Yes, the most appropriate answer is 2 mm, but in the clinic, on the off chance that you have a single margin with no EIC in a low-grade tumor, and you're going to give RT, you could consider not revising that margin, but that is a calculated risk and a discussion you have with your patient. So what do we know about the adjuvant therapy? We know for today that you do a lumpectomy. If it's VANU prognostic low risk, you could avoid radiotherapy, but if it's intermediate to high risk, you are going to give radiotherapy. All of this data comes from large randomized studies. You've got radiotherapy reducing the risk of invasive cancer ipsilateral DCIS, with obviously no effect on contralateral disease. You've even looked at data on mastectomy for radiation post-mastectomy for DCIS with no obvious benefit. We've got Oncotype DX, which is a 12-gene panel, which talks about, can you avoid radiation in a group of patients? This data has not moved into the guidelines. It's been validated by multiple groups of, I think, clinicians across the world. What you need to realize is that a lot of this focuses on low-grade DCIS. And the VANU prognostic index for low-grade also potentially tells you you could avoid RT. I will come to additional data that gives you another hint towards radiotherapy or not, but that I think I'm going to leave to the last controversy. For hormone therapy, you've got ample data, 2 large studies that told you that tamoxifen reduced the risk of ipsilateral DCIS, contralateral DCIS, no obvious reduction in ipsilateral invasive tumors. Yes, there is a trend towards it. We still continue to use tamoxifen over AIs in DCIS because one of the studies was positive, one of the studies was negative. And I think what we know is that you do have AIs in your armamentarium. So a group of patients that you want to probably evaluate the role of an AI, you could consider it in some postmenopausal women. Would you offer chemotherapy? And I think I'm going to leave that to a very ambiguous answer because I don't think for a pure DCIS you have enough answers. But for a DCIS with microinvasion with multiple foci, yes, you would want to consider it even if each foci is only 1 mm, because that's a heavier burden of disease, and especially if your patient's ERPR negative and HER2 positive, even in the microscopic focus. If, however, your patient is ERPR positive in the microinvasive focus, you could consider avoiding other systemic therapy and chemotherapy. What you do know today about targeted therapy, and to say that I would not ask for HER2 because it is currently still experimental, I think we need to move forward from, because today you know that HER2-directed therapy, though it's not part of standard treatment, because the NAC-BP B43 study did not show you enough events to tell you that yes, there was a benefit with it. What you know today is that it provides prognostic information. It is a poor prognostic factor for DCIS also. And very recently in 2021, data from the UK ANZ study was reevaluated looking at HER2 expression in DCIS. And what they did suggest that not only was it prognostic, it was also predictive of radiotherapy benefit. So you may want to ask for HER2 in your patients with DCIS, just to add whether or not you really need to offer this patient radiation, and especially if your patient's ever considering avoiding radiation in high risk or high grade DCIS. Another thing that I would say is that moving forward with it, if you've got multiple foci, you always ask for IHC on the DCIS and the invasive component. Your IHC needs to have been checked on both components if possible, and you treat whichever is ER positive if you have a target, and if your invasive component is HER2 positive, which we often see, you should look at how many foci you have and discuss with the patient what her other risk factors are. For a young patient with a 5 centimeter tumor where you've picked up multiple foci in a background of DCIS, all of which are microinvasive, you may still want to consider the role of systemic therapy with targeted therapy. So where are we today is to understand the most basic point. Screen detected and palpable DCIS are 2 distinct entities. Guidelines available to us are all for screen detected, and we need to develop our own guidelines for palpable DCIS and DCIS with microinvasion. Low risk DCIS, which are screen detected, there are multiple studies ongoing to evaluate the role of surveillance alone. High grade palpable DCIS have a high risk of microinvasion. Microinvasive foci should be quantified just not for number, but also to distinguish between IDC in a background of DCIS or what is truly microinvasive DCIS. Sentinel node or low axillary sampling for high grade palpable or patients undergoing mastectomies must be considered. Margins of 2 mm are considered as negative for DCIS, even if associated with IDC. Both hormone therapy and radiotherapy reduce the risk of ipsilateral DCIS recurrence. Hormone therapy also reduces contralateral disease. Radiotherapy reduces ipsilateral invasive disease. And today, HER2 positive is a prognostic factor, and it is also predictive of benefit from radiotherapy. Thank you so much.
Thank you, ma'am, for that comprehensive talk, summing up everything. We go on to the last segment for today, and which is questions for our experts. So I request all the examiners, moderators to come online. I have directed these questions to specific examiners. However, we would request everyone to chip in. First question to Geeta ma'am. So LCIS, exactly how different is it from DCIS, and what's your management protocol for the same?
So we all know that LCIS has been, stepped down. It does not feature in the AJCC manual anymore, but it is in the sense that you have to still take it seriously. You cannot just let it pass if it were to be seen. DCIS definitely falls into the spectrum. So if you have an ADH, goes on to become a DCIS, and then that going on to become an invasive breast carcinoma, that is part of the spectrum. But LCIS is no more in that spectrum. You could say that it is a harbinger of a pre-malignant condition, but it is not part of the in situ carcinoma anymore.
Right. Neeta ma'am, any addition from your side?
Well, exactly what she said. I think that with LCIS, because you're not sure that there is a hidden component of IDC, if you've got a lump which you've picked up something specific, radiologically, there is some suspicion. You're not going to just leave it alone if it's just LCIS. You would want to biopsy it or excise it if possible. And DCIS, I think, unfortunately, as of now, even low risk, you're going to have to go ahead and wide excise and treat.
Right. So our second question to Vijay sir, if he's there, in a invasive carcinoma post neoadjuvant therapy, if we have DCIS in the final histopath, how do we define PathCR, and how would we plan our adjuvant therapy?
I think PathCR has been defined as absence of invasive disease in the breast or in the axillary lymph nodes. So, I mean, the presence of DCIS is, of course, not as good as having a PathCR, complete absence of invasive disease. So, it would probably classify as Path PTIMIC rather than a complete T0.
Right. So, Neeta ma'am or Geeta ma'am, would you be changing the treatment? Would you consider the PCR and continue with your PCR treatment, or would you change it, considering it no PCR?
So I'm actually just going to add a little controversy to that. Sticking to exactly what Vijay said, I'm not going to call this no PCR. PCR is defined as absence of invasive tumor, so that's fine. But there is new data which actually suggests that if you've got IDC with DCIS, and even your DCIS component is HER2 positive, there's some data which now tells you that that DCIS HER2 component has started responding to NACT. So it changes your extent of disease. That's new data that's coming in that's being evaluated. And it's actually quite scary for us, because if you've got a wide area of DCIS, we give neoadjuvant chemotherapy, we would have bracketed all that calcification later and excised it. If it disappears with the HER2-directed therapy and the newer HER2-directed therapies that are in the system, we're going to have a little bit of conversation on local recurrence at a later date with the tumor sizes that we see.
So,
would this be classified as RCB0 or RCB1?
So I think the pathologist would still classify it as RCB0.
Okay, thank you.
Yeah, so if I were to, look at DCIS, if I were to see extensive DCIS bracketing, I would not be doing that. I would be having this discussion right in the beginning that I'm not trying to save your breast, even if all of this were to disappear. Because with DCIS, DCIS, why would it respond to chemotherapy in the first place? And the other thing is your PCR, is more relevant to your invasive component. So all this thing about, HER2 positives and the triple negatives with the change of treatment in terms of, residual disease, I don't think it applies to DCIS because, DCIS would not be seen as residual invasive. So when we're talking about change of treatment, it is to the residual invasive rather than to the residual DCIS.
Yeah. Thank you, ma'am. A third question to Gaurav sir, I don't know if he's there. And I think ma'am also touched upon it, that less than 2 mm margins. So what all factors would you take to decide whether you revise it or not?
So I'm just going to reiterate the same thing I said.
Yeah, yes, ma'am has already covered it in her slide. Any input?
So if you have a single margin, low grade, no EIC, and it's maybe about 1 mm, you could possibly, and the patient's definitely getting radiotherapy, then you could possibly consider not revising that 1 margin.
Just focal positivity is where I would let go. If it is more than focal positivity, I would definitely go in for resurgery.
Our last question, Paget's disease with a normal mammo and MRI, how would you proceed, ma'am?
Central quadrant excisions. I think I would be quite happy doing that.
Yes. So the whole purpose of doing the MRI it is, in fact, Paget's is one of those conditions where MRI is the imaging of choice, because a lot of times you will find completely unrelated areas of involvement with invasive carcinoma, and there you would not offer conservation. But if it is limited to just the nipple, just as Neeta said, central quadrantectomy with a Grissotti or a melon slice or whatever needs to be done.
Right. That's all from my side. I thank all the examiners for patiently answering all these questions. I invite our convener, Dr. T.S. Rao sir, to kindly give his concluding remarks.
Good evening. I thought that was one of the best sessions ever, and the choice of chairman, the moderator, and the examiners was something that was done by true consensus of the academic council, and we are very happy and proud of ourselves that we have actually chosen you all. Sadashivam sir, I think, has always been an awesome inspiration. I've seen him for the past 2.5 decades, same enthusiasm and tremendous endurance in whatever he does. So his presence has been the highlight of the evening. Geeta, of course, Geeta, I think we need many more Geetas in IASO. You hand over a job to her, she does it better than anybody else. And that's what she has done. She has put in so much of hard work and brought in every possible clinical detail into her case capsules. I think that requires commitment, that requires hard work. Really appreciate her presence. DG Vijay is a great friend. So he's more resourceful than anybody else. You go to Ahmedabad and he'll provide everything, scientific feast and everything else. So he was an automatic choice because he's one of the best brains in breast surgery in the country. So really appreciate his presence. Neeta, of course, I've never heard her, but I'm sorry I've never heard her because I'm not a very prolific breast surgeon. I'm not a true breast surgeon these days, and I'm very glad IASO has actually introduced Neeta to me. She spoke so well, and it was so comprehensive. It was an amazing talk, Neeta. We'll keep seeing you much more often in IASO and other fora, wherever I am into. You will also be there. So the advisors, I've always been doing the background work. So all of them are seniors. The distinct quality of all of them is that they give space to people like me and Srajan. And the president, we have a very, very dynamic president, very active, works so hard and so consistently for IASO. The secretary has not been there. Once again, a very, very dynamic young secretary we have. And the executive council, all of them deserve a pat on their back and a special praise for allowing us to do this. And it's very heartening to understand that the YouTube link gets so many hits. The previous sessions, and this session would stay very high on the list. Thank you very much for this wonderful session, all of you. I don't know if I've forgotten. I should thank Srajan Shukla, our own consultant, and then it's all his hard work that goes into the conduct of IASO academics. Thank you very much.
Thank you,
sir. Next one is announce the next one, Srajan.
Our next topic would be chest wall tumors, which would happen on the 13th of January, same day, Thursday, same time, 7 p.m. I hope that all of you join again.
Thank you.
Thank you very much and good night.
Thank you.
Good night.
Thank you so much. We'll conclude this